You can start, Dr. Joy.
Okay, fantastic. I'm Dr. Joy Baker, a practicing OBGYN in LaGrange, Georgia, and I am absolutely delighted to be here for this fireside chat with Dr. Camille A. Clare, who is the president-elect of the American College of Obstetricians and Gynecologists. Tonight is all about science and heart, the next chapter for safer births. This is presented by Safer Births Now and Birthing the Magic Collaborative, and we are delighted to have each of you here. I see some of you already typing in the chat where you're from. I see Philadelphia, Indiana, Fort Wayne, Arizona. So thank you all. Oh, and New York City. Thank you all for joining us here this evening. I want to get right into the conversation so that we will have plenty of time to entertain questions from the audience by the time we finish. So, first of all, I would love to introduce Dr. Camille Clare. As I said, she is the president-elect of the American College of Obstetricians and Gynecologists, the main body that OBGYNs like me get our practice guidelines from. So this is a big deal. Before we talk about leadership and policy, though, Dr. Clare, I would love for us to just get to know you a little better. Like, tell us a little bit about yourself and what first inspired you to become an obstetrician gynecologist.
Thank you, Dr. Baker, and thank you to the Birthing the Magic Collaborative and this opportunity to speak to colleagues and friends and those in practice who are equally taking care of birthing people and people that are wanting to be giving birth or all throughout their life course. I'm really excited about the opportunity. So I think if I go back far enough, my interest in medicine started when I was in high school, as a teenager. When I was 15 years old, I wanted to be a doctor. My mother worked in healthcare. She was a microbiologist, so I had some exposure to life in the hospital. And in high school, I did a pathway program where I was exposed to medical students at Columbia University. So I learned a little bit about the process of going to medical school. I learned about anatomy. We did all kinds of dissection on all kinds of things that probably were strange and unusual, sheep's brains, cow's eyes. So maybe that was my initial touch into the surgical part of my life. And then when I was a medical student, I had the opportunity to follow a pregnant person in their last trimester of pregnancy, and observe her birth. So maybe that I was my initial experience as a doula per se. I was a support person for her during her birthing experience and was able to follow her and her family, her daughter, Gabby, who we took care of or observed her healthcare experiences for all of our years of medical school. And then I made the decision, obviously, as a medical student, to pursue obstetrics and gynecology, which I don't regret not one second. It was the best decision of my life.
Wow, that's amazing. I think I was bitten by the OBGYN bug as a medical student as well, seeing that first birth. So, now that we've been out in practice for a while, what continues to bring you joy on a day-to-day basis in your practice?
I think what has really excited me most about what I do for a living is really the special relationship that I have with my patients. So, from the beginning of my earliest opportunity to take care of someone, all the way through their life. And so that's what I really, really enjoy. Obviously, I'm excited still about the birthing process. I love obstetrics still, and I still do practice obstetrics. So, but I'm really just excited about just the relationships that I've had with my patients and their families, which is really undescribable. I think there's no other field of medicine, in my opinion, in which we have that relationship with our patients through the highs and the lows. And I think that's what makes obstetrics and gynecology so special as a field. So I really chose the right one for myself. I also just love the opportunity of doing something potentially different every day. And probably that's well suits my personality. I like taking care of many people, many things at the same time, balancing many things. My mom used to say, well, you're too hyper to be a doctor. No, I just had to choose the right field. And obstetrics and gynecology serves all my personality traits. And just really, mostly, I enjoy my relationship with my patients. That's if I had to take anything away from anything that I say about people, it's just a close bond that I have with my patients, and just being so thankful for that opportunity. It's just a unique opportunity that we have, I think.
Oh, yes, that deeply resonates with me because I think we're uniquely positioned to make such an impact on families, communities, and women throughout their lifespan. So I definitely agree with you there. You know, I am just, I don't know, I'm just so excited because you are soon to make history as the first African American woman to serve as the president of the American College of Obstetricians and Gynecologists. So, beyond that historical significance, because I know it means a lot to me personally, I almost get a little
Mhm.
emotional thinking about it.
I do too.
What is your vision for your year as president? I mean,
Mhm.
it's such a short time span in the grand scheme of things.
Yeah.
What do you want to do with this presidency?
Yeah, thank you for that question. I mean, I think the impact of the time frame I've been well aware of even before I started as president-elect. So we've started to do some of the work that I will take on even further and expand and amplify during my presidency, which is critical access and rural health care. So I've been an urban physician, practicing in an urban area for my whole career. I worked in underserved areas in New York City throughout my career. However, I've practiced in a safety net hospital. So I've really practiced in settings that are low resourced, doing excellent evidence-based care, but under low resourced settings. So I do have an extremely important understanding of what that means. And so the impact of that specifically in rural areas is more important now more than ever. So we've started to, take up the mantle of the infrastructure of what we hope to do. This is not only an area of interest for ACOG, but how can we work with our key interested parties, all of our partners, in taking care of individuals in these rural settings. So other types of healthcare professionals, other types of physicians, other than obstetricians and gynecologists, working with other organizations to really move this work forward. So we've already started work since October of 2025, putting together a team of individuals. We've started an access to healthcare advisory group working with many individuals, ACOG members throughout the country that are already doing best practices in this area, in their communities where they practice. You work in Georgia. We have colleagues that have shared their best practices in places such as Nebraska, Iowa, etc., New Mexico. So Colorado. We have a lot to learn. I have a lot to learn. And so that's what we hope to not only continue for this year, but the next 2 years. And then how can we be sustainable in these efforts? So I'm really excited about it. It's resonated with a lot of people when I speak about my areas of interest. And so we're just excited to lay the groundwork so that others can continue to take the mantle on even after my short period of time on this precious seat, is complete.
Oh, wow. I'm really, really delighted to hear that because, I've practiced in small and rural towns my entire career after training in an urban, under-resourced area. So that is going to be something that I think is going to make a major difference for docs like me who are members of ACOG, who, are trying to do the best practices in areas where we may not have the best resources. So I think that's going to really be a big impact for those of us who are working in small and rural towns. So I'm very happy to hear that. I would love also to hear a little bit about some of the best practices that you talked about that you guys have been implementing in District 2 of ACOG, because you're from New York, right?
Yes, yes, yes. Thank you for that question. And thank you for all that you're doing and our listeners are doing in those rural areas that I mentioned, because many of our colleagues, as I go around the country, are already doing some great, great things. In New York, in District 2, several years ago, we developed an initiative called the Safe Motherhood Initiative, or SMI, and that is actually available for free. There is an app that people can download for free, that they can access these resources. And what we have been able to do is focusing on patient safety bundles. So these are sort of algorithms for practice to address some of the 5 common areas where individuals are experiencing maternal mortality as well as severe maternal morbidity. So things such as OB hemorrhage, or hypertensive disorders in pregnancy, things such as sepsis, venous thromboembolism, cardiac conditions, all of the major areas where our colleagues need additional help and resources to help them take care of individuals that are experiencing these conditions. So as a result of this work, we have been able in New York State, we are originally 48 out of the 50 states in maternal mortality since 2013, and now we're 15 out of 37. And the reason why I say 37 is because not all states report this information anymore. So we've done a really great job. However, we have a lot more work to do to help our colleagues really implement some of the recommendations that are evidence-based. We use evidence-based tools and information to help our colleagues create these resources and to create this information for our colleagues, which anyone can use. It's not only for OBGYNs, it's for our nursing colleagues, it's for our midwifery colleagues, it's for our emergency medicine colleagues. We've also, by the summer, will be implementing information on substance use disorder and how to take care of individuals, clients, and patients that are experiencing substance use disorder and how it impacts their pregnancy. So I think what we've learned is that we work together in a collaborative way, hearing from our colleagues what is working in their particular settings that are a variety of settings. It's not only New York City. We're also thinking about areas upstate New York, which are also can be rural areas, can be limited by resources. So how are we able to use these tools so that they can be applied in any area of the country, not only the state where I work, but any area of the country you can use these resources and they're available to you. It's hard for me to talk and put things in the chat, but hopefully someone can look that up. It's called Safe Motherhood Initiative, SMI. It is free. I don't get not $1 if you look at any of the resources. They're accessible to anyone. And please take a look and let us know if it helps or what we can do better, because it's been an iterative process since 2013 or so, and we've improved upon this process over all these years to help our colleagues as we take care of patients.
Wow, that is such great work and such necessary work. In all of the work that you guys have implemented in District 2, have you seen any significant decrease in the maternal health disparities?
Yeah, so I think that's kind of what I alluded to. I think because of some of this information, I also sit on the New York City Maternal Mortality Review Board and the New York State Maternal Mortality Review Board. We have 2 in our state, one for New York City and one for New York State. And I think by utilizing a lot of this information, we've seen some differences, right? How we're able to apply this information for all patients that we're taking care of. So I think and you may experience some of these similar challenges in your hospital systems or where you're working. How can we work with our hospital-based colleagues to get some of this information, this de-identified information, right? Especially nowadays, based on race and ethnicity and all kinds of lived experiences of our patients, it's getting more challenging, right? To get some of
Mhm.
this data nowadays. So, we've done this earlier on several years ago. How can we continue to demand this information so that we're seeing that what we're applying to our patients is applicable to all of our patients, right? Do we need to think of other resources for patients based on their lived experiences or the social drivers that people experience? Do they have access to things such as housing issues or food insecurity? All those things, as I'm sure you know in your practice and many of our colleagues know, can affect how people are able to access care. And then the other thing is, how can we continue to work with our community partners, right? So most of what you've seen and what the data shows is that 80% of these preventable deaths are occurring, most of them after 1 year after giving birth. So these are patients that are experiencing issues beyond the time that they're in the hospital, right? They're outside of the hospital setting. So how can we work with our colleagues and our partners to provide resources and help to our patients beyond the immediate period of childbirth and beyond the time when they're in the hospital or birthing setting, when they're actually giving birth. And I think that's what's so critical, that we continue to work with our colleagues to figure out ways in order to take care of people better.
I love what you said about community partnerships because we know that many of the maternal deaths that are preventable are happening in that postpartum period, long after the patient has gone home from the hospital, and maybe months and months after that person has given birth. And so, you touched on building community partnerships and building trust. And, in many communities, medical mistrust continues to be a significant barrier to folks seeking care. From your perspective, how can we rebuild trust, as physicians with patients, and foster more positive, transparent conversations? I mean, we're all living in the social media age, and I've joined a few, TikTok and Facebook groups to just sort of see what patients' experiences are and what they're saying. And, some of it is not very complimentary to us as physicians and particularly obstetrician gynecologists. So how do you think we can bridge that gap and rebuild that trust with our patient bases?
Yeah, that's a really great question. I think part of that is owning the harms that have occurred, right? So not only historical harms, which are extremely well known, or hopefully well known about our specialty, but current harms that may be happening in our hospital settings, in the areas where we practice, where we continue to practice. So one, recognizing the harms that we've done, so owning that, as well as building that trusting relationship so that we become trustworthy as well. We are worthy of our patients' trust, and that requires improved communication. How are we including our patients? Thank you for the heart sign. How are we including our patients who really have a strong understanding of their own bodies? That takes a lot for us to do, right? We learn about many bodies, but unfortunately, I don't know if you've seen it in your practice. My patients don't read the books. Their bodies don't go according to what Gabby tells me and Williams and all my textbooks tell me. Sometimes they're outside of that. So I think one, listening to our patients, that's really, really important. The CDC had a Hear Her campaign several years ago about really strengthening our listening skills. my godmother would say, you have two ears and one mouth for a reason, right? You're supposed to be listening twice as much as speaking. So allowing that, how can we improve our communication with our patients, listening to our patients, even when what they're saying is outside of our understanding of what could be going on, using the best evidence that we have when we're able to have it, right? We don't always have good evidence for everything, but we try to focus on evidence-based practice, and that allows us to improve that misinformation and disinformation that is rampant, especially in tools such as social media, which has unfortunately allowed misinformation and disinformation to be generated. I can tell you one example that ACOG successfully did was our campaign regarding acetaminophen, right? Tylenol in pregnancy. And because we were able to refute any misinformation and disinformation, hopefully that was one of the ways we were been able to continue to improve trust with our patients. So listening to patients, hearing from them, having them as important partners in our relationship, can allow for continuing to build that physician-patient relationship, and also, most importantly, eliminating legislative interference, right? Others in the policy side that may be interfering with that relationship that we have with our patients. So all of those things are so critical, I think, in helping improve trust and to make ourselves trustworthy as obstetricians and gynecologists, in my opinion.
I love that. That's going to be my takeaway from this conversation is being worthy of our patients' trust and
Yes.
owning harms that have happened in the past and that are happening now, even. So I think that that was just chef's kiss. I really think that's a huge thing that we have to do and to be honest about the shortfalls that, have happened so that we can then move forward together. And the legislative interferences, have been very interesting. Patients being afraid to even come in and ask questions and receive counseling and education about certain topics. That just does not need to be a part of our relationship with the patient. So thank you for that very thoughtful answer. One of the other things I thought of as you were talking about how ACOG successfully ran this campaign about making sure that people were made aware that acetaminophen in pregnancy has not been linked to any of the adverse outcomes that it was sort of being touted to have been involved in. Many of the ACOG districts now are working towards having a response for misinformation and disinformation, and also having a voice on social media. I always say if we're silent, then people will take they will take what they're hearing to
Hmm.
heart and
Hmm.
actually take that for expertise
Hmm.
when the true experts are not speaking. So I think it is important for us to be able to talk about that. And so I guess in your perspective, how do you see the ACOG districts working to sort of bring some good information? I've seen a huge increase in the information ACOG is putting out on social media. They're posting almost every day things that we can share with our communities and our patients. During your time as president, are there any special things that you want to actually put out into that meta space that all of our patients are living in now?
Yeah, I mean, I use the social media tool to amplify, right? Amplify what ACOG's message is. So I don't have any particular areas other than the area that I mentioned to you, right? So critical access in rural healthcare. So what we're doing on that. And just a shameless plug, on April 7th will be our next learning collaborative. ACOG will be hosting a learning collaborative at 7 p.m. Eastern Standard Time. It'll be online to find the QR in which to register, but that's an opportunity for folks to listen in, join in. It's a webinar similar to this, where again, we'll just be able to allow our colleagues to share their best practices and the work that they're doing to help in this area. So I will continue to use that tool in that way to amplify that message. So I think that's what's really critical, to continue to place evidence-based medicine front and foremost in the best we can when we're talking to our patients and our colleagues.
Absolutely. Now, you mentioned rural access and critical access to care. Are there any specific strategies that you've seen work really well and be very effective in improving access in areas of the country?
Yeah, so I just recently heard in one of the first webinars that we had, Learning Collaborative webinar that we had in March, they're doing work through the Indian Health Service. There's a manual that had been put out. It's called OB Red. It's a readiness manual that speaks to things such as simulation for physicians working in emergency room settings. So emergency medicine colleagues, how we can provide information and equipment and tools such as having an OB hemorrhage cart available in the emergency medicine setting, how to set that up, how we can provide some of these resources so that if individuals are faced with a pregnant person or a person who's imminently going to give birth, how to assist in those situations, if any emergencies come up. So that was one of the resources and tools that we learned in those learning collaboratives. So I think, and that was created by doctors who've been working at the Indian Health Service. So I think those kind of tools and information, I think, is very, very helpful. We're going to focus on areas such as workforce. So how can we continue to amplify, how can we get physicians and colleagues to work in those areas, as well as some policy issues such as the Rural Obstetrical Readiness Act, which was a piece of legislation that was put forward in 2024 to continue to get legislative support for that bill. And that also provides access and resources to our colleagues in these areas through legislation. So things along those lines are what we're working on, and continuing to offer things such as training for residency programs and fellowship programs for these rural areas. So those are just some examples of what we hope to do, and then how we can continue to be sustainable in these efforts.
Yes, we are actually seeing in Georgia, we have two now rural residency tracks with some of the medical schools. And I'm very hopeful that those are going to lure more brand new, well-trained OBGYNs out into areas like mine,
Mhm.
where I'm working. So I'm glad to hear about that. We've talked a lot about the science and best practices, and I would love to switch back to the heart. Your colleagues often describe you as someone who is deeply devoted to your patients and the doctors that you mentor. And how has that commitment shaped your leadership style? And how do you hope to support the next generation of OBGYNs who are coming behind us?
Thank you for that question. I think what I've learned is that obstetrics in particular, as well as gynecology, I would imagine there's an art and science to it. So the science we learn, but I think the art of it comes from how you can care for and truly empathize and just love your patients. So first and foremost, as an obstetrician and gynecologist, I am an advocate and an activist for my patients. That's well known. I say that every time I speak. And then how I'm able to relay that true love of what I do to my colleagues that I train and that I work with for the next generation. I'm an OG now. I didn't realize I was an OG, maybe a couple O's and a G now. And so really just sharing that feeling so that I'm training and helping individuals have a passion for their patients, regardless of really what they do for a living, but able to really love on them so that they're really able to hear their patients in the way that they need to be heard. So I think that's probably where the passion comes from, because I love what I do, and I'm so thankful and humbled by the gift. It's truly a gift to be able to take care of people in this way. So how can I share that gift with others?
Wow, I think that's such a testament to who you are as a physician and as a person. I will have one last question before we start entertaining some questions from our audience. So, guys, if you have questions that you would like to pose, please go ahead and start typing those in the chat. But, you know, I am just in awe of the fact that we are just having our first Black female president of the American College of Obstetricians and Gynecologists.
Mhm.
You know, and that's something, but we don't want it to become the main thing, right? Because you have a platform, you have things that you plan to accomplish. And when you are done with this year as president, you know, what legacy do you hope to leave, not only for ACOG, but for patients, physicians, communities? You know, what do you want your legacy to be?
That's a great question. You know, I've had to reflect on that for obvious reasons over the last several months. And I recently visited the University of Pennsylvania, which is a place where Dr. Helen Octavia Dickens worked. She was the first Black woman to be board certified in obstetrics and gynecology in the country in 1950. And so that has really allowed me to reflect on legacy. And I didn't even learn about Dr. Dickens when I was a medical student, nor in my training many years later. So, which is so unfortunate. So, I recognize that I will be the first, but I hope that I will not be the last. And I hope that whatever I'm able to accomplish is more than sufficient to allow others to develop what their own legacy will be. And I think it's very, very big. The role is very, very big. But I think for all of us, being the best doctor that you can be, the best midwife, the best nurse, the best anesthesiologist, the best doula, the best person that you could be is even more important than this job that I've been blessed to have. So I think more than anything, I hope that that's what I'm remembered for, even more than the role that I have, which I recognize is very, very important and what I prayed for. So thank you, God, for giving me what I asked for. But then be careful. You might just get it, what you asked for. So I'm
Absolutely.
thankful. Hmm.
I always say it's a blessing to be overwhelmed with the life that I prayed for,
That's
because
right.
it is such a big job. There is a lot of responsibility, not just in taking care of your own patients as a OBGYN, but now leading America's OBGYNs. That's a huge mantle to take on. And I just want to thank you for all of the very thoughtful commentary that you shared with us this evening. And I want to turn our attention to some of the questions in the chat, 'cause I want to make sure we can get to
Mhm.
as many folks as possible. And Marie, if you can help me out, just keeping an eye on this. I think I see where Imagined Possibilities had a comment which says rural areas include ambiguous designated urban areas with rural characteristics. And so urban areas are plagued with a lack of transportation and multiple negative social
Mhm.
determinants of health. And we need individuals who approach the challenges with systems thinking instead of applying traditional thinking strategies and evidence-based practices that don't fit in the current
Mhm.
environments. They don't fit the constituents or birthing families. What do you think about that? I think that's a very, very interesting thing. And you did touch on how you were looking at how we could have tools that could be implemented wherever. Would you
I
expound on that a little bit?
I love, love, love that question. I think what I learned in my experience working in Central Brooklyn, which I worked for 4 years as chair of my department at the time, we use things such as an academic partnership with our community-based organization. So it was a women's health community advisory board that really helped, work with us in a bidirectional way so that we had this sort of tailored to fit approach. And I've learned that at the time when I was working in Brooklyn, I was a part of our School of Public Health and learned a lot from our implementation scientists. So these were PhD colleagues that were not in medicine, but what I learned from them is that how can you use the tools that you've learned and how can you tailor that to the settings in which you work, right? Or which you live. So not everything is sort of like a one size fit all approach, but sometimes you need to tailor that and you need to tweak that. And you know how to tweak that based on what? The input of your patients, of the community. They're the ones that are going to help us really tailor to fit that approach. So we learn this evidence, as best we can, we apply it to our patients, but sometimes we need to take a tailor to fit approach. There's a lot of rules that are part of the hospital systems in which we work that, are may or may not be created in terms of policies and procedures by us, but how do we need to tailor that to our patients' needs in the settings in which we work? So I learned that, when I worked in Brooklyn and probably the other areas in which I work. So I think that that's been so important. To what I've learned. So I love that question because I think for myself that worked in safety net hospitals for many years in East Harlem and Brooklyn and the Bronx, just taking what I've learned, but sometimes you have to tweak it to context. What I did in East Harlem, I couldn't do in Brooklyn, right? What I did in Brooklyn, I couldn't do in the Bronx, right? So not everything is, you have to take that flavor, right? We get that from our community, our patients, that flavor, and how can we change it, right? Or twist it or tailor it to fit our patients. So I think that's what I've really learned. And I think giving our colleagues the tools to do that, that takes a lot of tools and learning. So how can we take some of those tools to do that, applying that to the rural setting, to these urban areas, the critical access areas, I think is what we hope to learn from this initiative that we're going to be working on over the next couple years.
I agree. I think that is such a great question because as I'm a part of a large health system here in Georgia, but I'm in the more rural areas, and so some of the things that are being done at the mothership, where there's a large footprint and many resources and specialties, don't really fit where I am. So, what we've really done is try to reimagine, like, how can we get the same outcomes and provide the same standard of care, even though we may not have all of the resources. So, reimagining, rethinking. For instance, in my clinic, we are setting up a way for us to have access to high risk specialists right here in the clinic. So we are able to send ultrasound images to the mothership and then have the patient actually get to talk to the perinatalogist right there in the office via a secure virtual platform. So there are lots of different ways. I think that what we've done in the past in our traditional
Mhm.
ways of doing things have not ended well for us. Like, we haven't been able to meet the demands for quality and safety that we need to meet to keep our patients safe. So I love that you talked about how to reimagine this and the bi-directional, right? The
Mhm.
old public health adage is nothing about me without me. So
That's
we're
right.
designing programs for communities. That community needs to be front and center at the table, helping us to design things that will actually work for that community. So I really believe that. I think that was a great answer. We had one comment, or question rather, about unnecessary interventions, including C-sections. Um, so, these are things that might be spurring mistrust. Are there particular stances that ACOG has about this or that they plan to implement? One thing I did see at my hospital was the AIM bundle on promoting vaginal delivery. And we were able to implement that, and everyone took a course on, how to avoid primary C-section if possible. And the truth of the matter is that some people just are going to need a cesarean delivery, unfortunately. But I do agree that there are things that we can do. For instance, all of our nurses got certified in spinning babies and they started positioning patients and using peanut balls. And it really did help us decrease our C-section rate at our hospital. But I don't know of any resources that ACOG might have other than that promoting vaginal birth toolkit.
Yeah, I can't speak to that exactly, but I would say that in general, I think some of the work that I've seen or I've heard about through many of the areas include obviously the NTSV work, so the nulliparous singleton term vertex, efforts to reduce that primary cesarean birth is so important. So I can't speak exactly to ACOG stance on any of that. I wouldn't speak to that, but I would say just as we continue to focus on evidence as best we can, focusing on a lot of the clinical tools that are available, I think are really, really important. That as best as you're able to apply those to your particular patient's context is really important. And you mentioned something earlier in your conversation about the use of telemedicine and sort of how can we use this referral system approach, right? So, for example, in my particular practice, because we practice very similarly in East Harlem, we had a very high vaginal birth after cesarean rate, right? Because we practice in a very similar way. So, how can we refer patients to practices that are able to accommodate their needs when we ourselves in our practice may not be able to accommodate certain things are important if we're able to, right? If you do XYZ procedure and another colleague does not, how can you take care of someone by referring in an appropriate way to someone else who does something that your patients wants that maybe you do not particularly offer in your practice, I think is super, super important. We know for many, many reasons the cesarean birth rate has been increased because of the increasing levels of comorbidities that patients are experiencing that allow them to have a cesarean for many, many reasons. So I think that's part of it, but allowing for, multiple ways that you mentioned in your practice, peanut balls, which I offered in my practice, ambulation during birth, walking, pain medication relief options, many things that allow for patients to have control of their childbirth experience as best we can is what we all aim to do if we're able to. And that's speaking
Yeah, I
for
agree.
myself as an individual, not necessarily what ACOG says.
Right. And two, I think that we are seeing sort of a shift, particularly on social media. Folks are like wanting more physiologic birth and they want more movement and they want to be able to have more of or maybe less of a sterilized clinical sort of birth, which I can, understand why the pendulum is sort of swinging back that way because of some of the C-section rates and some of the um, interventions that can occur at hospitals. But I think, it's up to us to sort of understand what our patients are asking for, what is important to them, and then figure out how we can safely implement the things that our patients want. I think that's really a big deal, is just having that humility to, like you said earlier, listen to the patient, hear the patient's concerns, hear about their wishes, and then have a conversation about it. I think shared decision making is something that is so important as we all strive to deliver the best care. I think, that communication back and forth, that relationship of trust is really so important. I have a budding doula in training who wanted to know, what do you suggest in terms of reading materials or coalitions that they should join or pay attention to? And I just love doulas. I think, we have a doula integrated health system where I work, and they have made all the difference in my practice. I spent today with the Georgia Community Doula Collective. So we were sort of having these same kind of conversations. But anything that you would recommend for doulas who are in training?
Well, I'm going to always tout the resources that ACOG provides and which is available to folks. We actually have a patient-facing part of our website, which is acog.org/women's health, all in one. And it's a patient-facing information and materials that is accessible to the public. So I think that's a start, right? As being familiar with what those resources are that our patients may be reading is very, very helpful. And then ACOG does provide that evidence-based resources for those who are providing obstetrical care, but being familiar with those are helpful because our patients, those are tools that our patients will be reading and that I refer my patients to. I don't get not one dime if they take a look at those resources, but I know that they are accurate and they are correct. I was looking at one of the comments in the chat and a colleague was asking about other areas of misinformation and disinformation. So ACOG has spoken a lot about things such as vaccination in pregnancy and advocating for vaccination in pregnancy. So many different types of vaccines that are safe in pregnancy. So that's another example in which we're speaking about evidence-based medicine and guidance for our colleagues.
So this next question, I actually got a chance to talk with our Georgia community doulas about today, but there were some concerns expressed about medical staff coming up with policy to bar or remove doulas from the room. And I think what we're really getting at with this question is how do we build more collaborative relationships with doulas, community health workers, midwives? Like, how do we sort of make the OB care team more inclusive?
Yeah, I can share an example in my own practice. Similarly, when I was in Brooklyn, we worked with the hospital system, so our own hospital, worked with our nursing colleagues to develop a policy for doula support within the hospital. So, with our doula colleagues, we had a community-based group of multiple individuals providing doula services, or multiple organizations in which our doula colleagues were working, several types of organizations, not just one. And we work with them as a group to develop a policy for doulas within the hospital system. So I think that's an important start. I think actually developing a policy that says, yes, this is separate from our visitation policy. This is how doulas are supporting our patients within the hospital. Those things are quite important. So if you're able to work with your obstetrical colleagues, with your midwifery colleagues, with your nursing colleagues, with your hospital administration, I think that's extremely important. We also worked with our chief medical officer. So all the upper important leaders within the hospital setting, so everyone can, with our security department, so everyone can really weigh in and have an understanding of what doulas do and how they're providing an important support for our patients. So that a patient a doula comes in to support their client or their patient, they're not stopped by security at the front desk. So having everyone have an understanding of what our colleagues are doing is really important. So I continue to support that.
Absolutely. There are a couple of questions in the Q&A that I wanted to see if we had a few minutes. We have about 8 minutes left.
Mhm.
Um, so someone wanted to know about ACOG. They said ACOG had a major influence on standardizing the clinical team's readiness, recognition, response, reporting, and ability to do so by respecting the individual and family. Are you able to share how ACOG seeks to support that beyond the HRSA partnership?
Right. So we no longer accept federal funding as an organization. So that HRSA program is no longer in its current iteration through the AIM program, the Alliance on Innovation in Maternal Health program. So more to come. We've just started some work through the ACOG Foundation, which is different than the ACOG as an organization, working on a quality and safety program. It's a patient safety organization. So more to come in the future about what that looks like. So because we're no longer accepting federal funds from the HRSA program, it's not the current iteration of what that program was before. So more to come about what that looks like in the future.
Okay, with mentorship being such a critical component to your practice, how would you like that to expand so it becomes a normal practice under your charge? And I guess we're referring to as in other OBGYN physicians across the country.
Yes, so I'm not exactly sure what our colleague is referring to. However, we do have sort of a formalized mentorship program within ACOG. So there is a way for folks to sign up if they're looking for a mentor within ACOG, and many different structures. So there are 12 districts that make up ACOG geographically, based on our geographic states and so forth. And so there's a lot of mentorship that goes on sort of locally, right, where people are practicing in the areas in which they live, in which they work. So I think that occurs all the time. But the other thing that I really try to advocate for is not only mentorship, but also sponsorship. So bringing people in to those opportunities when you hear of them. What are those opportunities to be involved in a national committee, or to be involved in a task force as available, or to be involved in a local legislative committee or things like that. So I think providing those discrete opportunities for individuals to get involved in whatever way that they can, I think is really, really important. So not only mentorship, but I also believe in sponsorship.
That is such a very important statement there, because we know that when you have mentorship and sponsorship, you're able to go much further. Like, you learn from your mentor, but when you have a sponsor who may or may not be that same person, that person sort of promotes you and propels you and asks you to do that. I think my mentor and sponsor is on tonight, Dr. Keisha Callens, is listening from Jamaica, and she has sort of pushed me into roles that I probably never would have tried to take on my own. And so that sponsorship is huge.
Mhm.
In 2019, ACOG released a position statement that mothers and birthing people should be allowed to labor and birth in a more physiologic fashion to decrease unnecessary interventions. This attendee wanted to know about intermittent monitoring or telemetry monitoring, and allowing for patients to labor and ambulate and change position and have nutrition in labor. They wanted to know that what you've seen since this rolled out in 2019. What have we seen at the bedside in terms of medical education, and what we're seeing in the hospitals now that patients are the ACOG stance is that we should allow patients to have a more physiologic experience of birth.
Yeah, I've seen that in my own practice, as I've said, probably even before that particular statement, but definitely in my own practice, in a couple settings in which I've worked, I've seen that really being practiced. So really allowing for those techniques that were mentioned are supporting that. So I think more to come as individuals are getting more and more information about what this is involved, but also it takes a little bit of the will of our colleagues that we work with, right? So our nursing colleagues, our colleagues within the hospital systems, to really support these efforts. So it takes really all of us to advocate for these things for our patients. So I think that's what's so important about the team-based approach. Are supporting our colleagues that are doing midwifery, our obstetricians, our nursing colleagues, our doula support colleagues, our anesthesia colleagues are very, very important as we are supporting our patients in the way that they would like to give birth.
Right. And Jay, hey Jay, he wants to know about community health workers
Hmm.
and folks who are outside of the clinical setting.
Hmm.
What do you see their role in addressing the social drivers of health, of health outcomes that we see in communities?
Yeah, I mean, I had in my own practice, I had an example where our community workers would see patients in the office with us, so in parallel with us. So not only outside of the hospital setting, so within the hospital setting. So we used our collaboration with our community-based partners to provide sort of collaborative work in thinking about unmet social needs of our patients as we're addressing their clinical concerns. So our community health worker partners really helped us get additional information about what was going on with our patients that might impact the care that we give, right? So I think that's so important, how to establish those relationships in whatever way that looks like in the settings in which you're working are really important. So working with your hospital system or your birthing setting system in your offices to establish what that looks like is really, really important. And that requires an important knowledge of your community, right? You kind of have to know your
Mhm.
community to kind of know what the resources that are available to you are. So working with your systems in order to make those connections and to hear about that information is really key.
Fantastic. I think we'll take one more question before we wrap up.
Mhm.
And the question is, there seems to be a lot of comments and questions in the chat about the the stance on working together. And I think ACOG's stance has been very clear that this is a team sport, particularly obstetrics, right? Because none of us are able to be there 24/7 with patients. So we need everyone pulling in the same direction. But I
Mhm.
think it might be nice to speak to some of the folks who may be feeling like they're not a part of the team or they're ostracized. What do you say to those midwives or doulas or community birth workers who don't feel like they have an inroads to be able to be a part of that care team and work collectively with the clinicians on the team?
Yeah, I think that's what we spoke about earlier about the importance of of communication, right? So I think actually being in rooms together is really, really important. I was introduced to midwifery models of care when I was a medical student. I had that good fortune. So because that was very familiar to me from my training, that allowed me to have an understanding of what the midwifery models of care are. On the counter to that, also, I would say, how are obstetricians part of the team as well? How are obstetricians a welcome member of the team is important as well, as needed, as appropriate, right? We're not always the main members of the team, but should we all be a part of the team? Just like I'm a NFL football watcher, every single person in the team is critical to the team. So I think how we can all have that approach allows us all to go to the Super Bowl and win, right? So that's our
Right.
goal. To our
Yes, we
goal is
want to
to play
win.
our part. Hmm.
We want to win and we want to all be part of the team. And so I can totally get that. And I think it does take communication and collaboration. And it also takes us putting away some of our own historical misgivings about some of the other people on the team, right? We have to all play together and play to win. Well, we are at the top of the hour, and I would just really like to thank you, Dr. Claire, for taking the time to speak with our audience, to be here with us this evening. I can't wait to see you be inducted at ACOG next month as the first African American female president. I am an OG too, but I might have a little tear at that moment because
I'll
it's
have a
going to be
lot. I'll have a
such
lot.
a, just such a huge moment for many of us in the crowd. So with that, I will wish everyone good night. Thank you to everyone who came out and participated in this conversation. You guys have been a fantastic audience. Also, thank you to our sponsors, Birthing the Magic Collaborative and Safer Births Now. Thank you. Good night.